Hello, welcome to the February education. My name is Herb Corlew, paramedic down in Whitney. This month, we're going to do a continuation of what we covered last November, that's STEMI to the OMI shift. And we're doing this shift really just to include up to that 40% of missed occlusions that really didn't meet classic STEMI criteria. We're going to cover multiple things, including the hyperdynamic T waves, Wellens. We're going to touch on the Winters pattern as well as posterior. Throughout this, we're going to go through a lot of pathophys, and we're also going to include 12-lead examples and case studies. Starting right off, we're just going to present a quick case study for us to reference now, and then reference as we continue through the education itself. Rolling right into this education, I'm going to go ahead and present a quick case study and 12-lead for you. 12-lead should pop up on your screen now. Let's consider this case study. You're dispatched to a 55-year-old male, chest pain radiating to the left shoulder. You arrive, ground ambulance provides you with this 12-lead. Go ahead and take a moment. We're going to assess that 12-lead as you would in real world. Go ahead and think about your considerations, what might or might not meet STEMI criteria, what looks odd or weird to you. And then go ahead and consider what your treatments or treatment course might be while you have this patient for the next, anywhere from 10 minutes to the next hour. Now, getting back into our primary focus, I'm just going to touch on some previously covered information, of course being the 2025 guidelines with the American Heart Association and American College of Cardiology. Really, that just takes the more classic STEMI criteria and expands it out a little bit. So, of course, with the classic STEMI, you're going to look for those new or presumed new left bundle branch blocks. You're going to look for those reciprocal ST changes and depression. Symptoms of myocardial ischemia, again, anything such as chest pain, chest pressure, shortness of breath, abdominal pain, and the elderly, all the way, and then including elevated biomarkers. That's your troponin. The STEMI diagnosis is still primarily ECG based. With that 2025 update, they do include OMI, or the occlusive myocardial infarction paradigm. The guideline acknowledges this shift towards OMI, however, still emphasizes classic STEMI criteria. The expanded criteria also places emphasis on posterior MI, the D Winters pattern, and hyperacute T waves. Rolling right into hyperacute T waves that don't meet STEMI criteria. So that also includes dynamic T-wave changes, and the definition and clinical importance of the dynamic T-wave change is its evolving amplitude, evolving symmetry, and polarity. And this will occur over minutes to hours, and often does indicate an occlusion occurring. These can pseudo-normalize as the actual occlusion and injury continues. Many of these patients with dynamic T-wave changes are at true risk of having a occlusion, and they generally do benefit from reperfusion despite not meeting standard STEMI criteria. Rolling into some common dynamic T-wave patterns to recognize, that will be your hyperacute T-wave. That's your very tall, very broad T-wave that generally doesn't match up with the QRS you're assessing it with. And these will generally occur earlier on in the cascade. Also, you may find that T-wave pseudonormalization, again, taking those previously ischemic or inverted T-waves, and they will become upright as the injury evolves. You may also have progressive T-wave inversion, taking those initially very tall peak T-waves and later inverting as that infarct progresses. Going into very specific and named patterns, such as D Winters, that includes upsloping ST depression, paired with tall peaked T-waves in the precordial leads, and these are very sensitive or specific for LED occlusion. So how do dynamic T-waves differ from static T-wave abnormalities? We see many patients with chronic cardiac issues who oftentimes have at baseline very jumbled EKGs. So going into these key differences, so temporal changes, right? Dynamic T-waves change over short intervals and oftentimes can be caught through serial 12 leads over minutes, and that can be easily accomplished over a 10-minute to a 30, 45 plus minute flight, taking a 12 lead every 5 to 10 minutes. Static or chronic abnormalities generally don't change within that short period of time that we actually see these patients. Dynamic morphology generally correlates with active ischemia. Anything changing, active ischemia. And then these will generally precede or replace ST elevation. These dynamic T's often appear before ST elevation or instead of, making them critical OMI markers. Now let's look into the timing and evolution on serial ECGs. So in your early phase, which is minutes to hours, you will have those hyperacute T waves, and they will oftentimes be the first actual sign on the ECG. Intermediate phase, hours into days, ST changes may develop, T waves can pseudo-normalize or begin to invert as the injury evolves. And on into that later phase, days to weeks, you will have T-wave inversion as well as Q waves begin to appear, and that pretty much represents a completed infarction. So what are our diagnostic and management implications for hyperacute and dynamic T waves? Generally, do not wait for that classic ST elevation to appear. Or in the hospital setting, generally not going to wait for troponin. When dynamic T wave changes are accompanied by ischemic processes or symptoms such as escalating pain, hemodynamic instability, ventricular arrhythmias, treat as a possible OMI, as a true ACS event. Serial ECGs are absolutely critical in comparing them from both ground or facility to your own. And then including a practical recognition checklist is very important, such as, is chest pain ongoing or recurrent despite analgesia? Are T waves unusually tall, broad, or asymmetric compared to prior ECGs? And are these T waves changing through serial retakes? Now we can kind of get into specific coronary arteries and how they present with these hyperacute and dynamic T wave changes. With your LED, most common affected leads are your precordial, your V1 through V4, and these may also extend all the way to your V5, V6. AVL, also if proximal LED, and oftentimes seen with your D-Winters pattern. Key patterns with the LED is loss of normal R wave progression, and often rapidly progresses to ST elevation. With your right coronary artery, you have inferior wall involvement. Again, your primary leads affected are 2, 3, and AVF. And you'll generally find reciprocal changes in 1 and AVL. Key patterns are similar. You have hyperacute T waves in inferior leads. T waves are often tallest in lead 3. Additional clues with the right coronary artery is consider your right-sided 12 leads. Try to get a V4R if possible, and also just be very mindful of bradyarrhythmias or AV blocks. Moving on to your left circumflex, these are often under-recognized. Your leads affected are 1, AVL for a high lateral, as well as V5 and V6. You may also see these appear in posterior leads, such as your V7 through V9. With your posterior changes, you may have tall T waves with horizontal ST depression in V1 through V3. Clinical pearls or hyperacute T waves are regional generally and not diffuse, which is also another tool to help differentiate between hyperkalemia. They can be short-lived and often change, and generally treat as an impending STEMI or OMI. Now let's cover some pathophysiology and the immediate consequences of OMI. With an abrupt occlusion, you have a movement from aerobic metabolism to anaerobic. Oxygen delivery falls dramatically, and ATP production generally stops fairly quickly. Without ATP production, it will then go into pump failure. Following pump failure, you will have a potassium efflux with leaking from the myocytes, causing a regional hyperkalemia, inducing ischemia. You will see these hyperacute T waves due to ischemia based on a faster repolarization of ischemic myocardium and slower repolarization of the surrounding tissue. The result on the ECG will be tall, broad, and peaked T waves. Now let's discuss why hyperacute T waves are regional and not diffuse. So only the myocardium supplied by the occluded artery becomes ischemic. ECG leads facing that affected area detect exaggerated repolarization. And then ECG leads surrounding that area show reciprocal flattening. And this is in contrast with hyperkalemia, which is diffuse, narrow peaked, as well as with early repolarization, which is stable, chronic, and non-dynamic. In summary, hyperacute T waves occur due to regional hyperkalemia and ischemia. Now, rolling on to named and specific changes within the OMI paradigm are Wellens. Wellens syndrome generally shows a high-grade LAD or left main coronary lesion. There are two types, type A, concerning about 25% of the cases, and type B, concerning 75% of the cases. With your type A case, these patients generally present pain-free and with biphasic T waves in the anterior leads. During pain, you have paradoxical pseudo-normalization of your ECG. Pain-free is usually within the first minutes and generally changes within hours. With type A, full occlusion is likely to occur within days to weeks. Moving on to type B, you will find deep symmetrical T wave inversion in 1 and AVL, and your chest leads will generally have 1 millimeter of ST elevation. Rolling into why these biphasic T waves occur, the mechanism is related to reperfusion of the affected ischemic myocardium. With a transient LAD occlusion, you will have ischemia. Spontaneous reperfusion will cause altered repolarization, and this produces abnormal T wave morphology rather than ST elevation. Now let's roll on into the De Winter's pattern, which is considered an anterior MI equivalent. With your De Winter's, you're going to have tall, prominent, symmetrical T waves, generally in your precordial leads, that's your V1 through V6. You'll find that upsloping ST depression, and you may also even have ST elevation in the AVR, generally 0.5 to 1 millimeter, fairly subtle. This pattern is often seen in younger male populations, generally around 40 years old, and may precipitate a dangerous arrhythmia. So that's been our discussion on hyperacute and dynamic T waves, including both Wellens and De Winter's. Now Mr. High is going to come in, talk about the modified Smith's Sgarbossa criteria, and then roll on into our case studies.
What's up, Eric?
Hey, brother, hold on.
Hey guys, my name's Hi. That's Hi like hello. You'll hear that from me. I'm a flight paramedic out of Gainesville, Texas. I'm going to be talking to you about Smith's modified Sgarbossa criteria and the left bundle branch block. So before we talk about the criteria, we actually have to talk about concordance and discordance. Right? Concordance is when your QRS complex is in the same direction of your T wave. Right? And discordance would mean that your QRS complex is in the opposite direction of your T wave. All right, so the reason why we're talking about left bundle branch block is because, you know, as a paramedic student, I was told that if you have a patient with a left bundle branch block or a pace rhythm, you wouldn't be able to identify if the patient was having an acute myocardial infarction. They said that if you knew that the patient was having a new onset left bundle branch block, then that's the equivalent of a STEMI. However, it's not very often that we're presented with an old 12 lead and we don't know how or when this patient's 12 lead changed either. So there are multiple studies on the Sgarbossa criteria, the Smith's modified Sgarbossa criteria. However, I just want you to know that these rules are highly specific and sensitive as well. Real quickly, I'm going to go over how we identify a left bundle branch block. For me, I use the turn signal method. So if you look at V1 or V2, if your QRS complex is greater than 0.12 seconds, you'll find the J point where your S wave ends, and you'll follow the direction of the QRS complex. So if it's up, it's probably a right bundle branch block. If it's down, it's going to be a left bundle branch block. So our first criteria is going to be concordant ST elevation of 1 millimeter in any lead. Our second criteria is going to be concordant ST depression of 1 millimeter or greater in leads V1 through V3. Our third criteria is going to be proportionally excessive discordant ST elevation in one or more lead with 1 millimeter or greater ST elevation as defined by 25% or more of the depth of the preceding S wave. I'm not expecting you to memorize that, but the other two are pretty easy to remember. So, all right, let's jump back into our case study that Herb presented to us earlier. So, looking at this 12 lead, it's an older gentleman, chest pain. It could be anybody, right? Old lady with epigastric pain, nausea, literally anything. So just remember that. These aren't very specific to any case. So looking at this 12 lead, it doesn't meet classic STEMI criteria, right? I don't think I see ST elevation pretty much anywhere in this 12 lead. But let's dissect it a bit more, right? It's a little irregular. I see some funky beats in there. But let's look at what really stands out to us. These are some massive T waves right here. Huge. Look how small the QRS complex is compared to that T wave. Right? So remember, your hyperacute T waves are going to have a broad base. Okay? They're going to be tall or taller, or just relatively taller than your QRS complex and peak. Look at the surface area on that T wave right there. Okay? So it didn't meet STEMI criteria, right? However, are we done with this patient? Are we done monitoring this patient right here? I wouldn't think so, okay? This is the kind of patient that you definitely need serial 12 lead EKGs on. Really, we should be doing serial 12 leads on any type of ACS patients that we have suspicions for, right? So let's say you didn't do a 12 lead, okay? All right, you go back to, you go to hospital and the facility does a 12 lead for you, and this is what they find. They're gonna look at you and be like, how did you get your job? You know what I mean? So here, yeah. So, but we're good clinicians, right? So we're gonna do repeat 12 lead EKGs, okay? And we're gonna catch these dynamic changes, right? So this is the same patient, okay? But now look at their anterior leads. We have massive, obvious ST elevation right here. Okay, look over here, huge, very noticeable. All right, so if we did serial 12 lead EKGs, good job, you just saved this guy. Probably not, but that's okay. Okay, so that was our anterior encroaching on our lateral leads right there. So let's go ahead and take a look at inferior leads. Right? Remember, these don't have to be massive T waves. You just have to compare them to the preceding QRS complex. Okay? So look here. I want you to look at this QRS complex here, right? And look at the T wave that follows it. Okay? See how large this QRS complex is compared to its following T wave? Now I want you to look at leads 2, 3, and AVF. Okay, look at AVF. The QRS complex is literally just a blip. Okay, but look at the T wave compared to that. It's huge. All right, same with all these other leads right here. So if you ever have, well, in this scenario specifically, in your inferior leads, if you see hyperacute T waves, or something that might kind of look like ST elevation, you should definitely look at AVL, because if you have ST depression or a T wave version of AVL, there's a good chance this patient is having an OMI. So, okay, let's take a look at our lateral leads, i.e. the left circumflex artery. All right. So, taking a look at this 12 lead right here, all I see is a sinus rhythm. It's pretty regular, no ST changes at all. My assessment would be the ABCs. Airway, breathing, and can you walk to the aircraft? Right? So, now, but we're good clinicians, right? We walked him to the aircraft, he's all snuggled up, no big deal, but we're gonna redo our 12 lead, right? Because this is a very dynamic situation. Okay? So, let's say we're mid-flight, okay? We took another 12 lead. Now look at the difference, right? Look at this beautiful QRS you had earlier. Okay, look at that very small T wave. Okay, that QRS kind of shrunk a little bit, right? And the T wave kind of grew as well. And now look, he's got T wave inversion, a little bit of depression in lead 3. So just another reason why you should be doing repeat 12 leads, okay? All right, and now for me, I feel like this has been drilled into my brain quite a bit, but if you have any ST depression in leads V1 and V2, you definitely should be suspicious of a posterior MI, right? Let's take a look at that. Okay, in this patient, you know, there is kind of obvious ST elevation already, right? But I want to say for a lot of these patients that are having posterior MIs, they may not have that. This will be your probably only sign right here is flat ST depression in your anterior septal leads. So keep a lookout for that. So it looks like this patient had posterior 12 lead done as well, or at 7, 8, and 9. And look at that. ST elevation. Boom. So let's take a look at our Wellens, or type A and type B Wellens here, okay? So looking at this 12 lead, you know, looks like a sinus rhythm, no obvious ST elevation, but that's kind of weird right there, right? Looks like this T wave kind of dips down below the isoelectric line. And here it's a bit more prominent, right? QRS here, below the isoelectric line. That would be your type A Wellens. All right. So remember earlier we were talking about how, you know, this is the type A Wellens is only 25% of those who have a Wellens. However, you know, these patients can develop into a full-blown occlusion within a couple weeks. So be mindful of that. And here's a good example of your type B Wellens right here. So we have nice inverted T waves, right, in all these leads here. And look how even they are. Look at that. Pretty. Alrighty, now let's go ahead and look at some OMIs regarding left bundle branch block and paced rhythms. So here we've got a 12 lead. QRS is kind of wide, right? Let's see here. Looks like 1, 2, 3, 3 small boxes. And using the turn signal method, you start at the J point, and then the QRS goes down or negative. That'll be a left bundle branch block, right? Remember, we can identify an OMI in a left bundle branch block. Don't just look at this 12 lead and disregard your findings, okay? So let's take a look here. We're looking for concordant ST elevation or concordant ST depression for the most part, right? Those are the easiest two to find. Here on 12 lead, it's already circled. See, your QRS is mostly upright, okay? And I have at about 1 millimeter elevation as well. So this patient's positive. Okay, let's look at our next example. So here, I've got a paced patient, right? You can see you've got pacer spikes down here, right? Now, remember, just because it's a paced patient doesn't mean you can't identify an OMI. So, looking at this, I'm looking for concordant ST elevation or concordant ST depression. This is a good example of discordance right here. See how your QRS is negative, but your T wave is upright? That's discordance. So, looking at lead V2, maybe V3, your QRS, you have your QA right there, leading mostly down, right? And then your J point is below the isoelectric line. So that's concordant ST depression. This patient would be positive as well. All right, so let's look at our final 12 lead example here, okay? So let's see here. It's wide. I see pacer spikes. This is obviously a pace rhythm, right? Now, right off the bat, I can see concordant ST elevation. In about 2 leads, it looks like. So we have an upright QRS complex, right? Our isoelectric line is about down here, and our J point is right here. So there's obvious elevation, greater than 1 millimeter. And it looks like we have it over here in lead V5 as well. I'll zoom in so you guys can see that. Awesome. But I think another good example of the third criteria actually might be in leads V2 and V3 right here. So looking at it, it's obviously discordant, right? Your QRS complex is the opposite direction of your T wave, right? However, all right, so it looks like there's a good amount of ST elevation right here, right? And to me, I would say that's about 25%, maybe more, than the amplitude, the size of the amplitude of the QRS complex right here. So, you know, it could meet the third criteria, but I wouldn't really hang my hat on that. So
that will wrap up this month's education. Key takeaways are that checklist that will help include both STEMI and OMI, such as current or recurring chest pain despite analgesia, hyperdynamic or acute T-wave changes, anything that falls within Wellens, De Winters, or posterior EKG signs. Do you have anything else for us?
yeah, just remember you're doing your serial ECGs, like Herb was saying. Don't discount or don't throw away your 12 lead when the ground crew hands it to you and says it's a left bundle or pace rhythm. So,
Sounds good to me. Again, my name is Herb.
my name's Hy.
Catch you on the next one.